Welcome to McTox Curriculum, brought to you in collaboration with Western University, University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum, built for residents and fellows from PGY 1 to 5. This topic is about alcohol toxicity. This presentation on alcohol toxicity is brought to you by Dr. Wahid Al-Hazani. By the end of this 10 minutes, learners would be able to 1. Identify ethanol-associated complications. 2. Recognize self-harm behavior. And 3. Discuss management of alcohol withdrawal. Case 1. A 27-year-old male presented with seizure. He is a known alcoholic and had multiple admissions for alcohol-related seizure in the past. His past medical history is significant for alcohol and drug abuse. He does not take any medications, nor does he have any known drug allergy. This patient looks unwell, agitated, and tremulous. His vitals are significant for a heart rate of 118, a blood pressure of 142/96, a rest rate of 20, and he's saturating at 96%. His temperature is 37.1 degrees Celsius. Focus examination reveals that he is confused to time and place. He seems to experience visual hallucinations. What do you think this patient has? This schematic diagram shows medical complications of ethanol. Ingesting too much ethanol may lead to its dependence and abuse, co-ingestions of street drugs or overdose, or issues from secondary trauma like head injury and subdural hemorrhage. On the other hand, when an alcoholic stops drinking, this may lead to either alcohol withdrawal syndrome or alcoholic ketoacidosis. We will give a brief overview of each one of these complications, then focus on alcohol withdrawal syndrome. Acute intoxication rarely requires any medical intervention unless there is a need for airway protection or breathing assistance. Chronic alcoholics may suffer from metabolic and electrolyte disturbance like hypoglycemia, hypokalemia, and hyponatremia. Patients consuming ethanol along with other drugs are at risk of developing interactions. While chronic alcohol consumption is considered a cytochrome P450 inducer and may interact with metabolism of other drugs, on the other hand, acute ethanol intake may temporarily inhibit cytochrome P450 enzyme system. In addition, taking ethanol with street drugs is not without consequences. For example, using cocaine at the same time as consuming alcohol is sadly not uncommon behavior. This results in the production of cocaethylene, which has about 5 times the half-life of cocaine alone. Alcoholic ketoacidosis is a condition resulting from failure of chronic alcoholics to consume food, either intentionally or due to persistent vomiting. This can be further exacerbated by sudden cessation of alcohol intake. In these situations, the body turns to adipose tissue for energy, which results in large amounts of ketones and lactic acid production, and consequently, a high anion gap metabolic acidosis. Treatment simply consists of administration of both fluid and glucose. Alcohol withdrawal is a spectrum of conditions, ranging from mild agitation, tremor, seizure, hallucinations, and most seriously in delirium and altered level of consciousness, and possible death. Importantly, a patient with seizures or an altered mental status should undergo thorough workup to rule out other causes of their presentation, including hypoglycemia, hyponatremia, or head injury. Patients with alcohol withdrawal should be assessed to determine severity and the aggressiveness of treatment required. Those with mild withdrawal may be discharged with oral benzodiazepine and appropriate community resources and instructions. Patients with moderate to severe withdrawal need longer observation periods and consequently closer monitoring. Revised CWA is the most appropriate tool to calculate the amount of benzodiazepine needed and the frequency that should be applied to all serious withdrawal patients. The main pharmacologic treatment is aggressive benzodiazepine for sedation. Furthermore, it is important to not forget correction of any electrolyte disturbances and to replace vitamins in these patients. Due to the effect of tolerance, serum ethanol levels do not accurately reflect the extent of intoxication in alcoholic patients. Therefore, an ethanol level should be interpreted carefully when it comes to determining things such as competency and the ability of the patient to make decisions. This concludes this presentation. Please consider the following questions. 1. What is the relationship between ethanol ingestion and acetaminophen overdose? 2. What is the risk of giving glucose to chronic alcoholics without giving them thiamine? 3. What type of ketone is predominant in alcoholic ketoacidosis?